We are live, sir. Please start.
Very good evening to all of you. So once again, welcome to the platform of Department of Urology, SMS Medical College, Jaipur. Today, we have a presentation on step-by-step approach of radical prostatectomy. So this will be presented by our second year resident, Dr. Saurabh Jain. And the moderator would be Dr. Somendra Bansal. So today we have two special invitees with us. I will just introduce. Just before we start, we will do a small prayer to Ma Saraswati.
Saraswati namastubhyam varde kamarupini vidyarambham karishyami siddhir bhavatu me sada.
Thank you. So today's we will start our session on radical prostatectomy. The two special invitees with us today are Dr. Gagan Gautam. Dr. Gagan Gautam, he is presently, welcome Dr. Gagan to our platform of Department of Urology SMS. He is a director now at Urologic, Oncologic and Robotic Surgery Max Institute of Cancer Care, New Delhi. He is alumnus of AIMS New Delhi and also did his fellowship at University of Chicago Medical Center. He is presently also the program director at Vatikuti Fellowship in Robotic Urologic Oncology. He has more than 65 reviewed index publications. He has done more than 950 robotic procedures, as is also the intuitive proctor and trainer for advanced robotic courses. So welcome, Gagan. Thank you for sparing your valuable time. And the next invitee with us today is Dr. Anup Kumar Gupta. We all know he is the Honorary Secretary of North Zone Chapter of Urological Society of India and is also the professor and head of the department at the Department of Urology and Renal Transplant at Safdarjung Hospital, New Delhi. He is also the program director of AUA Endourology Clinical Fellowship in Advanced Robotic and Laparoscopic Surgery. And he has been awarded with the prestigious American Urological Association Oncology Fellowship. He worked with Dr. Vipul Patel, and he was also awarded the prestigious AUA Chakravarti Fellowship, where he worked with Dr. Mani Menon and Dr. Inderveer Singh Gill. He is also the honorary faculty of eminence for robotic training in USI ISU. So welcome, Dr. Anup. Thank you for sparing your valuable time. And now I will request our moderator, Dr. Somendra Bansal, to invite our presenter today.
A very good evening, all of you. Now I invite Dr. Saurabh Jain to start their presentation. Dr. Saurabh?
Yes, sir.
Please share your presentation.
Yes, sir. Good evening, sir. Am I audible? May I start, sir?
Yes, Saurabh, you are audible.
Good evening, sir. Good evening, all respected teachers, seniors, and colleagues. Today I am presenting webinar on step-by-step approach for radical prostatectomy. Radical prostatectomy involves removal of entire prostate gland and resection of seminal vesicles. With a margin of surrounding tissue sufficient to achieve a negative margin, and pelvic lymph node dissection will also remove for high risk and localized.
Saurabh, just wait. Ashish, please reduce the interruption, please. Please reduce the disturbance that is there. Mute everybody, please. Ashish from the technical support team, please mute everybody. Why this ding dong song, this bell is there? Okay, Saurabh, go ahead, please.
Yes, sir. Goal of the radical prostatectomy. There are 5 goals. One is the trifecta. It will to survive, for it to achieved by the complete resection, will to remain continent, will to retain sexual function by the nerve sparing approach, and the other goals are the to achieve negative surgical margins, and surgery should be free of complications. Now the history.
Good evening.
First radical perineal removal of the prostate done by the French surgeon Proust in 1901, followed by the Young, who will first to describe the procedure at the Johns Hopkins University, the retropubic approach to the radical prostatectomy introduced by the Millian. Retrograde radical retropubic prostatectomy described by detail by the Chute and later by the Campbell in the 1950s. The procedure remained unpopular because of its high associated morbidity like significant bleeding and urinary incontinence and impotency. Riener and Bolch described the anatomy of dorsal venous complex and presented a technique for ligating this complex in 1977, which reduced bleeding and improved surgical exposure. Bolch later defined the anatomy of neurovascular bundle and reported the technique for the anatomic nerve sparing in 1983. Now the suitable candidates. Who have life expectancy more than 10 years with moderate or high risk cancers in cases of the T1, T2B organ confined tumors, and in the cases of the T2C in the selected cases. We should postpone radical prostatectomy followed by the truss guided biopsy for 6 weeks and followed by TURP for the 12 weeks. It will help to preserve neurovascular bundle and prevents renal injury. Now the various approaches for the radical prostatectomy are open radical retropubic prostatectomy, open radical perineal prostatectomy, and laparoscopic radical prostatectomy, and robot assisted radical prostatectomy. There are various techniques. Difference between various retropubic approaches are first of the perineal technique. It will first described by the Young. There are few cons and few pros. The cons are less blood loss and short operating time, while the pros are no access to the pelvic lymph node dissection and high chances of the rectal injury, and difficult to do nerve sparing radical prostatectomy and high chances of the positive margins. While in the cases of retropubic radical prostatectomy, which introduced by the Millians, there is more blood loss and increased chances of the obturator nerve injury and ureteric injury. But there is wide and good exposure and good pelvic lymph node dissection, and there is less chances of the injury for the rectum, and nerve sparing radical prostatectomy can be done easily here, and there is low risk of positive margins. While in the cases of the laparoscopic or robotic radical prostatectomy, very less blood loss, less pain, and faster recovery. But there are few cons, like it is a high cost, high learning curve, but one benefit is very low risk of positive margins. In the cases of laparoscopic or robotic radical prostatectomy, there are two approaches: transperitoneal and retroperitoneal approach. In the cases of the transperitoneal approach, which is most commonly used, there will be large working space, anatomy is known, but there are more chances of the bowel injury or intraperitoneal urinary leakage. While in the cases of retroperitoneal approach, there is less working space. Now the surgical anatomy for the radical prostatectomy. This diagram is showing the pelvic plexus of nerves supplying the sympathetic and parasympathetic nerve fiber to the prostate, urethra, and bladder. Also showing the inferior vesical artery and its branches. Now the pelvic plexus of the nerve formed by the visceral sympathetic nerves by hypogastric ganglion and visceral parasympathetic nerves by S2, S3, S4 division and somatic motor nerves. The nerve innervating the prostate travel outside the capsule of the prostate and the denovidular fascia until they perforate the capsule where they enter the prostate. The branches to the membranous urethra and corpora cavernosa also travel outside the prostatic capsule in the lateral pelvic fascia, posterolaterally between the prostate and the rectum. neurovascular bundle of Volge. Cavernous branches of the pelvic plexus join capsular arteries 20 to 30 millimeter distal to the prostatovesical junction. There is spray-like distribution in the lateral pelvic fascia between the prostatic fascia and the levator fascia, also known as neurovascular bundle of the Volge. At the apex, supplies branches to the prostate and striated sphincter in the spray-like distribution. There may be so many wide variations present. And it will followed by the piercing of the urogenital diaphragm and passes behind the dorsal penile artery and nerve, and ultimately enter the cavernous of the penis. This diagram is showing section of the prostate with nerve and vascular supply, also showing relation of the prostate with neurovascular bundle, seminal vesicles, bladder, rectum, and the various facial layers. Prostatic venous plexus. Superficial branch of the dorsal venous complex between the puboprostatic ligament lies outside the anterior prostatic fascia, while the deep branch of the DVC present between the prostatic and the levator fascia, and the lateral venous plexus, also known as central plexus. It is common trunk and lateral venous plexus are covered and concealed by the prostatic and the pelvic fascia. Prostatic venous plexus communicate with the pudendal, obturator, and vesical plexuses, ultimately drain into the inferior vesical vein and followed by the drain into the inferior internal like vein. Arterial supply. In prostate is supplied by mainly by the inferior vesical arteries. It is
Saurabh, just please. Ashish from Dr. Reddy's technical support. Ashish, Ashish, come in please. Ashish, I would request every rest of all viewers to please mute themselves. Please mute yourself and put your video off, please. All the viewers, please mute yourself and put your video off. Just a very humble request to all of you, please. Yes, Saurabh, go ahead.
Yes, sir. Arterial supply to the prostate. It is mainly by the inferior vesical artery which enter and divide in the posterolateral part of the vesico-prostatic junction. It divides in the two parts, urethral branches and the capsular branches. Urethral branches supply the bladder neck and periurethral part of the prostate, while the capsular branches on the lateral pelvic fascia, which present posterolateral to the prostate, supply its outer portion. Capsular branches identification landmark for microscopic pelvic plexus of the nerve. Prostate facial covering. There are three coverings of the prostate. First one is the prostatic fascia or capsule. It is present anterior and lateral in the continuity with the prostatic parenchyma. Anterior part of it lies dorsal venous plexus and centrovenous plexus. The second layer is the denovular fascia, cover posterior surface of the prostate and seminal vesicle. It will dense at base and thin at the apex. While third layer is the levator fascia, laterally fuses with the prostatic fascia, form the lateral pelvic fascia. It is showing in the diagram. Now the pre-op preparation. First of all, we will educate the patient pre-operatively and take proper consent. Then pre-operative pelvic floor exercises with or without biofeedback have been used with the aim of reducing the early post-operative incontinence. And the third point is the neoadjuvant androgen deprivation therapy for the 3 months period. Neoadjuvant androgen deprivation therapy is associated with the decreased rate of PT3. It will do downstaging of the tumor and decrease chances of the positive margins and low incidence of positive lymph nodes. Now the pre-op antibiotics and the deep venous thrombosis prophylaxis, which given before the starting of surgery. Now the position and anesthesia. Patient placed in the supine position with the chest size slightly hyperextended and the table placed in some 150 degree of Trendelenburg position for good exposure of the surgical field. We will prefer regional anesthesia as a combined spinal epidural, it is preferred, associated with the less blood loss, lower frequency of pulmonary emboli and DVT, faster recovery and reduced use of the opioid analgesic. A latex Foley's catheter at least 20 inches placed. Incision and exposure of the small pelvis after PND under aseptic precaution, around 8 to 10 centimeter midline extraperitoneal lower abdominal incision between umbilicus and pubis placed. Followed by the pre-peritoneal space of Ridges is opened and peritoneum is mobilized from Ridges space laterally up to the bifurcation of the common iliac artery. Then gentle cephalate retraction of the bladder and sweeping of the fatty tissue provide excellent exposure of the anterior aspect of the prostate and endopelvic fascia bilaterally. Prostatic anterior fat pad dissection and histological analysis. Presence of lymphoid tissue within the fat pad anterior to the endopelvic fascia. This lymphoid tissue is present in the 5.5 to 10.6% of the cases and contains metastatic prostatic carcinoma up to the 1.3% of the intermediate and high risk patient. The prostatic anterior fat should be removed at the time of the radical prostatectomy for exposure of the endopelvic fascia and should send for the histological examination. Now the pelvic lymph node dissection, when it should be done, it should be carried out before the radical prostatectomy. There are so many variations of the lymph node dissection. There is minimal, standard or extended lymph node dissection. In the cases of the minimal pelvic lymph node dissection, only the lymph nodes present in the obturator fossa are removed, while in the standard cases, removal of the lymph nodes present in the obturator fossa plus along the external iliac artery. In the extended version, complete lymph node dissection is performed along the obturator fossa and the external, internal, and common iliac vessels up to the iliac crossings of the ureter. In the cases of the low risk malignancy, there is less than 7% chance of the lymph node involvement, so there is no need of pelvic lymph node dissection. While in the intermediate or high risk cases of the prostate cancer, there are increased chances of the lymph node involvement, so lymph node dissection is required. Pelvic lymph node dissection, there should be obturator nerve, obturator and hypogastric vessels should be scleronized and preserved. In the cases of the extended lymph node dissection, those difference may be divided. In the cases of the pelvic lymph node dissection for radical prostatectomy, minimal 20 nodes to be removed. But in the cases of the radical cystectomy for the CA bladder, their minimum will be 25 lymph nodes. In the urothelial upper tract cancers, there should be 8 minimum lymph nodes should be removed. And send all lymph nodes in the separate pocket according to the Buchner's regimen. Frozen sections is not required if patient has well differentiated to moderately well differentiated tumors, Gleason grade less than 8, and the lymph nodes are normal on palpation intraoperatively. Incision in the endopelvic fascia and division of the puboprostatic ligaments with the lateral dissection. After the pelvic lymph node dissection, all fatty tissues covering the prostate and lateral pelvic wall dissected for exposure of endopelvic fascia, puboprostatic ligament, and superficial branches of the DVC. For the right side of the endopelvic fascia, retract prostate medially and start incising fascia laterally over the levator ani muscle, followed by extension to the posteriorly of the dissection, results in the good exposure of perirectal fat in the neurovascular bundle. Same maneuver will be repeated in the left side, followed by the dissection of the endopelvic fascia anteriorly until the puboprostatic ligaments are reached, and they will be divided carefully because periurethral component of the complex should be intact to preserve the anterior fixation of the striated sphincter. Division of the endopelvic fascia should be lateral to the vessels and divide puboprostatic ligament carefully so that pudendal vessels which are beneath the puboprostatic ligament can be preserved. Pudendal artery and nerve located just deep to the pelvic muscle. And these vessels should be ligated with the clips, small clips, to avoid coagulation injury to the pudendal nerve. Ligation of the DVC. Main concern is the effect of prior DVC ligation on the apical margin positivity rate and the continence recovery. Due to the proximity of the deep venous complex to the both the prostatic apex and the urethral sphincter muscle fibers, it should be matter of the concern. In the cases of the robotic assisted laparoscopic technique or laparoscopic technique, due to the increased pressure of the pneumoperitoneum, whether prior DVC ligation was used or not, blood loss was not found to be significantly different. Ligation of DVC by the figure of 8 horizontal mattress suture on the DVC caudally as far caudally as possible, and the other another suture placed on anterior surface of the prostate to prevent bleeding from the proximal dorsal venous complex. It is also known as a back bleeding stitch, followed by the division of the deep venous complex. Now the goal of the apical dissection. First goal is cancer control and preserve continence for maintenance of the potency and reducing bladder neck contractures. Although age and preoperative function may remain the most important predictors for the post-operative erectile function, nerve sparing has also been associated with the improved continence outcome. But the continence mainly due to the dissection technique, a thermal dissection, traction-free handling of the bundles used during the nerve sparing surgery, not due to the preservation of the nerve bundles themselves. Now the apical dissection in the non-nerve sparing radical prostatectomy, no definite decision can be made preoperatively. Decision will based only on intraoperative findings after opening of the endopelvic fascia. If there is palpable induration in the neurovascular bundle, no induration, but neurovascular bundle fixed to the prostate. If inadequate tissue present over the posterolateral surface in the specimen after excision of prostate, or in the cases of clinically T3 tumors or apical tumors, nerve sparing radical prostatectomy can be done. So proceed with the bilateral non-nerve sparing radical prostatectomy. In these cases, clipping and transection of the neurovascular bundles results in the complete mobilization of the apex, followed by the extrafacial dissection. It will be done between the denominal fascia and anterior propriorectal fascia. Denominal fascia included in the prostatectomy specimen. Apical dissection in the cases of nerve sparing radical prostatectomy, neurovascular bundle of Wolge. If nerve sparing is performed correctly, the prostatic fascia must remain on the prostate. This is called interfacial dissection. They are outside prostatic fascia, but within levator fascia. In the cases of intrafacial dissection, dissect beneath the prostatic fascia and directly on the prostatic parenchyma. There is less bleed, but high chances of the positive margins. Now the other techniques, apical and or anatomical approach of nerve sparing radical prostatectomy by the Wolge. Here nerve dissection initiated at the apex after isolation and transition of the urethra, while in the other approach known as lateral approach by Ruckel and Jinke, there is neurovascular bundle dissection done first, followed by urethral transection. Division of the anterior part of the striated sphincter, followed by the division of the apex, divide anterior part of the striated sphincter, followed by overswing of the striated sphincter and proximal dorsal vein. Now the division of the anterior part of the urethra. There is U or V-shaped incision on the paraprostatic urethra anteriorly, and for the unilateral or bilateral nerve sparing by the neurovascular, there should be neurovascular bundle present, left intact posterolaterally. Division of the posterior striated sphincter and encircling of the urethra. Posterior component will be released. Division too close to the apex of the prostate may damage the neurovascular bundle. So posterior component of the striated sphincter should be divided midway between the apex and of the prostate and urethra. Sharp division of rectourethralis muscle if present, for identification, correct plane between the prostate and rectum, midline dissection of denominal fascia up to the base of the seminal vesicles. Now the dissection of the prostatic pedicles. This diagram is showing lateral branches who are clipped first and divided, and the lateral and posterior dissection of the prostatic pedicles, followed by the bladder neck dissection and transection. First, bladder neck is dissect and transect in the anterior part, fill all around. Now the division of the VOS difference and removal of the specimen. For oncological clearance, the seminal vesicles have traditionally been removed intact with the prostate specimen. The cavernous nerves run past the seminal vesicle tips such that indiscriminate dissection of the seminal vesicle tips could potentially lead to the erectile dysfunction postoperatively. So preservation of the seminal vesicle tips may be considered in the cases of the low risk of involvement. Now, the reconstruction of bladder neck by the mucosal eversion and closure of the bladder neck. It will be done in the tennis racket fashion. First of all, we will inverted the mucosa by the 4-0 suture, followed by the eversion of the mucosa. In that case, interstitiation of the anterior hood of the tissue over the bladder neck for the post-op continence. And the final and most important step of the radical prostatectomy is the vesico-urethral anastomosis, primary end-to-end intermucosal anastomosis of the bladder neck to the membranous urethra by using 6 interrupted sutures placed circumferentially, as showing in the diagram, has become the standard method of reconstruction for open radical prostatectomy. In the end, after achieving hemostasis, Rocco stitch will be placed. It is running continuous absorbable sutures used for reapproximate the remnant denominator fascia, prostatic detrusor, and posterior rhabdosphincter. This serves to re-establish posterior anatomic support for bladder and urethra, improving urethral coaptation during voiding, reduce tension at the vesico-urethral anastomosis, and increase functional length of the striated urethral sphincter complex. So before closure of the wound, 2 suction drains are placed in the pelvis for keep residual space dry, followed by closure of the wound in the layers. In the after completion of the surgery, post-op care will be according to the enhanced recovery protocols. Post-operative pain managed by the patient control analgesia and epidural set, which is present by the epidural top-up. Orally, patient allowed orally only after the peristalsis restored, and the plan for the drain removal when the daily output is decreased less than 10 ml per 24 hours. Patient will be discharged usually on the day 5th or day 6th with the Foley's catheter in situ if patient is stable, and the PUC removal usually after 10 to 14 days on follow-up after do cystogram for check any leakage. But some centers remove PUC only after the 4 or 5 days if no post-operative complications present. After removal of the catheter, patient will be prescribed physiotherapy for the pelvic floor muscles. There are some complications, early complication and the late complications. Mainly intra-op complications are the bleeding, intra-op rectal injuries will be managed intraoperatively, and others are the urinary leak, fistula, DVT, vascular or ureteric or nerve injury, and post-operatively lymphocele, wound problems, and obturator nerve injury. Obturator nerve injury nowadays may be managed by the grafting of the genitofemoral nerve or the sural nerve. In the late complications, mainly are erectile dysfunction or urinary incontinence. Usually 100% immediate post-operative patients will face erectile dysfunction, but the gradual recovery will be occur 90% by the 18-month treatment in the phosphodiesterase inhibitors. In the cases of the urinary incontinence, main cause is the internal sphincter defect. Most common site of injury during the ligation of the dorsal venous complex, but usually more than 95% of the patient free by the 1 year. And other late complications are the incisional hernia strictures. Now the summary of the steps of the radical prostatectomy are after given anesthesia and positioning, there will be lower midline incision and followed by the extraperitoneal approach for exposure of the pelvis, followed by bilateral pelvic lymphadenectomy. It will done usually before the radical prostatectomy, and followed by the opening of the endopelvic fascia and limited incision of the puboprostatic ligament. We should not divide the posterior pubourethral part of the ligament as is anchored the urethra. Suture ligation and the transaction of the centroroni, dorsal venous complex, and the DVC by the figure of 8 suture, followed by the division of the striated sphincter and dissection of the urethra at the apex of the prostate and transition of the urethra. We usually preserve the accessory pudendal artery for the preservation of the erection and the neurovascular bundle also. Dissection of the seminal vesicles and ampullary portions of the vasa differentia will we do, followed by the transition and reconstruction of the bladder neck closure done in the tennis racket fashion. And the last and the important steps of the radical prostatectomy is the vesico-urethral anastomosis. Thank you, sir.
Thank you, Saurabh. Yes, I'm really sorry for the initial disturbance. This was probably one of the drawbacks of our technology sometimes. So I would now invite Gagan, Dr. Gagan and Dr. Anup both for their initial comments. And then what we will do is we will step by step just from the pre-op preparation, and then we'll go ahead and discuss about your views on the different steps of radical prostatectomy. Though he discussed about the open approach, I think rest of the steps are probably similar in both open lap or robotic approach. So Gagan, Dr. Gagan, are you there? Dr. Anup, you just initiate with your comments.
So I think there is, if I'm unable to unmute myself now, I'm managed. The host is not allowing to start video. Can I start video, please?
I'm really sorry. Now you are there, right?
Right. So I can speak, but I can't. Yeah, I can.
Actually, we told the host no to please mute everybody. So he muted the invitees also. I'm really sorry for that.
No, not at all. Not at all, sir. I can understand. I think overall, Saurabh's done a great job because he's covered everything very comprehensively, talked about all the steps, pre-operative preparation, post-operative things. Saurabh, तुमने मेरा अच्छा revision करा दिया आज. Thank you for that. There were just a couple of points that I wanted to talk about. Firstly, it's completely optional. This is not the, as you had suggested, sir. If you want, then I can present about a 7-minute video on the steps of robotic prostatectomy. But that is not really the thing. If there is any particular step that you want to discuss further, we can do that as well. The questions that I wanted to discuss firstly was that I think Saurabh, nobody's in the exam is really going to ask you the specific steps of a prostatectomy because by the time the time comes for getting to the steps, I think you have already passed your exam with excellent colors. The important questions here to be addressed are before the surgery, what are the indications for surgery? And then how do you counsel the patient? What are the steps that you take to have continence preservation, sexual function preservation? So sir, how would you like to go about discussing all this? Should we take up one topic each, or should we go ahead and ask questions? So you're muted right now. Yeah.
Yes. We can go ahead with, if you think proper, then we can start with the pre-op preparation and the imaging that you usually do in these patients. So let us see how would you go ahead if the patient has, suppose on DRE, he has a hard prostate or PSA is high, then which would you do a multiparametric MRI in every patient?
So should we address these questions to the third years and
yes.
And have a discussion with them?
Okay.
They are the ones going to be in the firing line soon. So let's see, how well they are prepared.
Okay, that we can do. Only thing is, I have told to only keep you unmuted, the rest of them to be muted. So I have to tell the technical team again to unmute them. Anyway, we can ask Dr. Saurabh. Saurabh?
Yes, sir.
So what would you do in such a case? If suppose a patient comes with a high PSA and suppose 15 PSA and DRE, he has a hard nodule, would you do a multiparametric MRI before doing a biopsy, or first do a biopsy and then do?
No, sir. First of all, sir, we will do the MP MRI of the prostate. Then we will go for the prostatic biopsy, sir.
Okay. So in every case, you will do a first multiparametric MRI.
Yes, sir.
Then do a biopsy. Okay. What is the advantage of doing a multiparametric MRI before biopsy?
Sir, there will be some least chances of some negative biopsy. If there is a single nodule or the small nodule present deep or present in the anterior part of the prostate, this will be easy for the radiologist or for the surgeon for go for a positive biopsy, sir,
Right.
by the MRI.
So Gagan, what do you think? Would you do a multi-parameter? Yes, please.
So, sir, I think that firstly, Saurabh, what you have to do is that initially you have to, in your mind, always, whenever a patient of prostate cancer comes along, the first thing that you have to assess in your mind is that, am I dealing with a low risk? Am I dealing with an intermediate risk? Am I dealing with a high risk?
Yes.
But we are even one step before that, because we are not yet diagnosed. We have not yet diagnosed the prostate
Yes,
cancer.
sir.
So, but any person who has a PSA of more than 10 is intermediate risk, and if it's more than 20, it's high risk.
Yes, sir.
So for a low risk prostate cancer, you may or may not get an MRI done. That is a different thing. But for an intermediate and high risk prostate cancer, you should get an MRI done. However, even if a person comes with a PSA of less than 10, you can use the MRI actually to decide whether you are going to do a biopsy or you are not going to do a biopsy. Number one. If there is a lesion that you can see on the MRI, you can also use that information, like you have very correctly said, to target the biopsy, to be able to diagnose prostate cancer, to be able to increase the sensitivity of your biopsy by targeting the using the information in the MRI to do what we call as a fusion biopsy. Now, the fusion biopsy can be of two kinds. One fusion biopsy can be that you use a specialized software where you combine the images of the ultrasound and the MRI and target the biopsy on the basis of that. The second type of fusion biopsy is what we call as a cognitive fusion biopsy, which basically means that you're just looking at an MRI picture. In your mind, you're trying to figure out where the lesion is, and then using that information while doing a truss-guided biopsy. So what is the role of an MRI prior to doing a prostate biopsy? Well, you should do an MRI prior to doing a prostate biopsy in any patient who has a PSA of more than 10 in any case, because that will fall into intermediate or high risk disease, and you should probably have information before you've done the biopsy. But even less than 10, you can use the MRI to be actually dictate the need for a biopsy and target it further, and as a result, improve your accuracy of your prostate biopsy.
Right, Gagan. So because between 4 to 10, and if the DRE suppose is normal, then again it's a gray zone, and the multiparametric MRI may help to decide whether the biopsies should be done in a particular patient or not. Right. Anup, please come in. Any comment you want to make here?
So I want to tell the residents that in exams you will get two kind of cases. One case in which you will have a small nodule in one of the lobes, in which you are suspecting it to be intermediate risk or high risk, or one case you will get in which you have both lobes are hard and nodular, and we are thinking about locally advanced prostate cancer. So in that scenario, we can say multiparametric MRI can be avoided because it's a hard nodular prostate. You can directly go ahead and do the truss-guided 12-course biopsy, because in that patient, the chances of getting the surgery is low. However, we know also in the locally advanced, you can do surgery as a multimodality treatment. But most of our examiners, they are of this view that if you have a locally advanced prostate cancer, you can get away without doing multiparametric MRI before the biopsy. So in that case, you can say, I don't want to go for a multiparametric MRI, I can go for plain MRI. There is no role of multiparametric MRI in that. You can go for plain MRI, or you can go for MRI after biopsy. So this is one scenario. Otherwise, like Dr. Gagan has said, all patients, they will benefit by doing a multiparametric MRI before biopsy, because you get a lot of information from that.
The other question, if I may interrupt, sir, that has been correctly said, the important thing here is that what is the situation in which you will definitely do an MRI before the biopsy? You will definitely do an MRI before the biopsy in a patient who has a previous negative biopsy. So you may argue whether you are going to do a biopsy, do an MRI before the biopsy or no in a patient where you're suspecting prostate cancer, but where a biopsy has already been turned out to be negative earlier, you will definitely do an MRI, and that is in the guidelines is a very strong recommendation.
I think the EU guidelines now say that the MRI, multiparametric MRI, should be done before biopsy in most of these patients. Anyway, then there is another point is the must wait period. So as Saurabh said that it should be around 6 weeks if the biopsy has been done and 12 weeks after TURP. What is your take on that period?
I would pretty much agree with that. 4 to 6 weeks is a safe period after the biopsy to wait before doing a radical prostatectomy. The other important point that I wanted to stress on was when you were talking about the indications, sort of indications of prostate cancer. I think instead of saying T2A, T2B, it's probably better to say, make things easy and classify them on the basis of low risk, intermediate risk, and high risk. So if an examiner asks you what are the indications of radical prostatectomy, then you would say that you can do radical prostatectomy in a patient who has a low or intermediate risk prostate cancer, and in selected cases of high risk prostate cancer. That would be the right answer for the exam. Now, if the question comes in the exam that the patient is suspected to have a lymph node positive disease, or a patient is suspected to have a PSA of more than 50, which constitutes very high risk prostate cancer, the standard treatment of that would be radiation therapy and hormone therapy. This question can also be put in the other way for the exam, that what are the treatment options for low risk prostate cancer? A low risk prostate cancer basically means a PSA less than 10, T1C or T2A on clinical staging, and a Gleason score of 3+3. For that, the number one leading option of treatment is active surveillance. In a patient with a life expectancy more than 10 years. Any patient with a life expectancy less than 10 years, any stage, any grade, the treatment option of choice is watchful waiting. Patient life expectancy more than 10 years, low risk prostate cancer, number one treatment is active surveillance. Number 2 and number 3 treatments, in whichever order you want, is radical prostatectomy and radiation therapy without androgen deprivation therapy. Intermediate risk disease, number one treatment option, radical prostatectomy versus a combination of radiation therapy plus 6 months of androgen deprivation therapy. High risk prostate cancer, that means PSA more than 20, Gleason score, Gleason grade group 4 or 5, that is basically Gleason 4+4 and above, or a T2C disease or above on clinical staging. The first choice is radiation therapy and androgen deprivation therapy. In selected patients, you may consider radical prostatectomy. Who are those selected patients? Patients with a very long life expectancy, patients who are young with no comorbidities.
All right. Now, suppose we have decided to do a radical prostatectomy in a patient, then what are the preoperative preparation that you will do? Besides the normal, usual routine investigations, would you start a PDE5 inhibitor before starting a radical prostatectomy? And others like Kegel exercises and other physical, you would counsel the patient about quitting smoking, physical activity, etc. Is it a routine protocol? Gagan?
Right. So now there are a couple of things. I noticed in your presentation, Saurabh, that you had mentioned about the role of neoadjuvant for surgery, that there is currently no role of neoadjuvant androgen deprivation therapy prior to radical prostatectomy. You have correctly mentioned that it reduces the incidence of positive surgical margins and it reduces the chances of finding positive lymph nodes. But it has not been found to make any difference in the chances of biochemical recurrence. It has also not been found to have any difference in the chances of requiring further treatment as adjuvant or salvage treatment. So it makes no impact on survival. It doesn't increase the chances of having a less chance of biochemical recurrence after surgery. So in any situation, there is no role of neoadjuvant androgen deprivation therapy. The role of neoadjuvant androgen deprivation therapy is in patients who require radiation therapy, and that is well proven, and you would always give it short term for intermediate risk and long term, which is 2 years to 3 years for high risk. Now, about the question that sir has asked, what are the preoperative preparation? Firstly, we need to counsel the patient about the course in the hospital, about the ERAS protocols, about the complications of the surgery. We need to spend a lot of, one of the important things is to ensure, to find out from the patient what is his level of sexual activity before the surgery. So we always do a SHIM score, the SHIM or IIEF score, and try to ascertain whether the patient has normal sexual function or doesn't have normal sexual function before the operation. If the patient already does not have a normal sexual function and needs a PDE5 inhibitor prior to surgery, the chances are very less that the patient will be able to recover normal sexual function after surgery. So that will help you in counseling the patient. Like sir has said correctly, you can give him a trial of PDE5 so that the patient gets used to using the PDE5 inhibitors prior to surgery in patients with normal sexual function, but normally, generally, as a matter of practice, it is not done. In some centers, they may be doing it, but not routinely. Usually, we started in the post-operative period. Beforehand only, you have to decide what are the chances of the patient being able to have a nerve-sparing surgery. So nerve-sparing surgery, you have to take a lot of factors into consideration. You have to look at the previous sexual function. You have to look at the size and the location of the dominant nodule on MRI. What does the MRI, is MRI telling you if there is any extra prostatic extension on that side? You would probably not be able to do nerve sparing. You have to look at the patient's clinical stage, his Gleason score. Patients with high risk prostate cancer undergoing radical prostatectomy are very rarely candidates for doing a nerve sparing. Similarly, if the patient may be having intermediate risk disease, but at the same time may not be sexually active preoperatively, so there is no point in doing a very close or intrafascial nerve sparing in such a patient. Secondly, you have to counsel this patient about continence and the chances that the patient will be at what point. What are the chances that at 3 months he will require pads? At 6 months, what are the chances that he will require pads at 12 months? Patient has to be told that what is the expected recovery of urinary continence. He has to be told about Kegel exercises, like you have mentioned, biofeedback. Not really biofeedback, we do regular Kegel exercises. These Kegel exercises should ideally start before the surgery so that the patient knows how to use and is able to isolate the Kegel exercises. One question that the examiner may ask you is that how do you teach a person to do Kegel exercises? The answer to that question is best way to teach Kegel exercises is to do a DRE and ask the patient to squeeze your finger with the anal muscles. That is the best way to isolate the pelvic muscles. Once the patient is able to do that, he knows which muscles to contract, and he should start it from before the surgery itself. About complications, apart from these things, you have to mention about anesthesia related complications, about surgical complications, infection, bleeding, need for blood transfusions, how long will the patient stay in the hospital. So all these form an important counseling part. Like sir has adequately said, patients should ideally be advised to quit smoking, start steam inhalation, and to have an active lifestyle with regards to which will help him in his recovery process.
Yeah. So what now we will do is, I think Gagan, you have a small video clip. We can go ahead with the video clip and step by step we can discuss a few points. And I would request Anup also to come in. Anup, if you have any comment on the pre-op preparation, then please do it. And then we will just ask him to start that video clip and then discuss the steps of radical prostatectomy.
So I wanted to clarify a few points, sir. Indication of radical prostatectomy, residents should understand that in high-risk localized prostate cancer and locally advanced prostate cancer, they should say radical prostatectomy as a part of multimodality treatment is the treatment, one of the treatment options that they should always remember. Number one. Number two, regarding the lymph node dissection, because this is often asked before we have to counsel the patient about lymph node dissection before surgery. So all these patients, if you are planning for lymph node dissection, they are the intermediate risk, high risk, or locally advanced. All will require extended lymph node dissection. So there is no terms like extended standard or a limited lymph node dissection. This is number 2. Number 3, the indication of nerve sparing. As Dr. Gagan has highlighted most of the indication, I just want to say in high-risk patients, if you have an extra capsular extension on one side, which is often the case, on that side, you have to sacrifice everything and go for wide resection. This should be your answer in exams. If you don't have extra capsular extension on the other side, you can try for a nerve sparing, not intrafascial, but interfascial, that is, which is between the two fascia. So this is answer you should give. One of the questions your examiner will ask you when you give that, they ask you it is an intermediate risk patient, it's a high risk patient. Options are radical prostatectomy or radiation therapy. How to decide? Most of the viva revolves around this question. If you cannot defend your answer, you will just go on, beating around the bush. So your answer should be radical prostatectomy because you are a surgeon. You prefer it over radiation therapy because number 1, if you do radiation therapy first and patient has failure of radiation therapy, you have to go for salvage surgery, which has got a lot of complications and it's very difficult to do and the results are not good. If we talk about functional outcomes like the continence or the erectile dysfunction. So this is number 1 argument you should give in favor of surgery first when you talk about intermediate risk or high risk. Number 2, after radiation therapy, the PSA nadir you do not achieve as good as you achieve after radical prostatectomy. Then you can follow up the patient in a better way after surgery as compared to radiation first. And then of course you should say oncological outcomes are better. They are equivalent in both arms, radiation therapy and surgery, but the functional outcomes in today's era because of the robotic technology is better in the surgery arm. This is how you should convince the examiner that yes, you will do radiation first. These are some of the points. I think this will come in the pre-operative counseling, and I think rest which Dr. Gagan has said, he has covered most of the things.
Right.
So Anup has made some fantastic points here, and he has already said them, but I am going to repeat just 1 or 2 things to reiterate more than anything else. He said about lymph node dissection. Correctly stated, lymph node, there is only 2 choices of lymph node dissection. Am I going to do lymph node dissection or am I not going to do lymph node dissection? Low risk prostate cancer, I'm not going to do lymph node dissection. Exam answer. What we do in practice is completely, don't worry about that. In exam, low risk prostate cancer, I'm not going to do lymph node dissection. Intermediate risk, high risk prostate cancer, I'm going to do lymph node dissection. Whenever I do lymph node dissection, I'm going to remove 3 groups of lymph nodes as per the guidelines, and they are the internal iliac, the external iliac, and the obturator group. There is no such thing as a obturator node sampling. An extended lymph node dissection, which involves removal of the common iliac, the presacral, has not really caught on this. As per the guidelines, internal iliac, external iliac, and obturator group for intermediate and high risk, no lymph nodes for low risk. Number 1. Number 2, there is no role of frozen section now for lymph node dissection in radical prostatectomy. Earlier on, it was thought that if you do a lymph node dissection and lymph nodes come out to be positive on frozen section, you abandon the prostatectomy and put the patient on hormone therapy. That is no longer the case. There are trials which have shown that people who do abandoning putting on hormone therapy alone. So currently, in the current era, there is no role of doing a frozen section in a radical prostatectomy. You will take your treatment decisions regarding additional treatment or salvage treatment or adjuvant treatment after you get the final pathology report. Similarly, there is also no role of frozen section from the pelvis, from pelvic lymph nodes in radical cystectomy. The same rule applies in prostatectomy as well. Right. So I think we can
Yeah, so Gagan, you share the in the meantime, you share the video. In the meantime, I will just want to know that some of the surgeons would do a frozen section biopsy of the anterior prostate fat or the prostatic fascia just to decide whether you would like to do a nerve sparing or not. So, is there any role of a frozen for anterior prostatic fat or the pelvic fascia, lateral pelvic fascia?
I would not, to the best of my knowledge. There are certain surgeons who are doing a frozen section of the entire prostate. I mean, initially, of course, Dr. Mani Menon and their group, they used to take random samples from the area of the neurovascular bundle and set it for frozen section to decide whether they are going to do any nerve sparing on that side or no. It doesn't really work because you may have a negative margin at one particular point, say at the base, but at the mid you may have a positive surgical margin. So later on, there have been studies done mostly from Europe where they have taken the whole mount section. They've taken the entire prostate out, and before doing the anastomosis, they have done a frozen section of that to see whether they have any positive surgical margins. And if they have a positive surgical margin, they excise the neurovascular bundle on that side.
Yeah, that's neurosafe model.
Neurosafe technique, right, sir. Right. But I don't think most of our centers in India, or for that matter, anywhere in the world, have that facility to be able to do whole mount frozen sections, because it's a lot of effort for the pathologist.
Right.
I don't think it's in the guidelines yet.
Right. Okay. Thank you. Let's go ahead. Yes.
So at any point, if you feel that you want me to stop or proceed to the next step.
Yes. So I would ask even Dr. Anup if he wants to make a comment on any of this step. Please, you are most welcome. And let's go ahead. Yes.
So this is a robotic radical prostatectomy, incision being made. You imagine it being done opposite to the way we do an open retropubic prostatectomy. Open retropubic prostatectomy is that we come from the apex backwards after dividing the endopelvic fascia. Robotic prostatectomy can be done in a number of different ways. This particular technique is the most common technique, where we first make an incision just in the pouch of Douglas, and we straight away go and dissect out the seminal vesicles and the vas. So bilateral seminal vesicle and vas have been dissected out here. And we are heading now between the rectum and the posterior surface of the prostate. Again, there are many variations of this. I'll just briefly run you through what has actually been done here. So that part has been taken care of. We have now dissected the seminal vesicles, vas, and gone right till the rectum, ahead of the rectum, right till the apex of the prostate. And this is the lymph node dissection which is being performed here. I also like to do the lymph node dissection before the radical prostatectomy. Here you can see the obturator nerve which is coming into view here. And the entire lymph node packet, which includes the internal iliac, the external iliac, and the obturator group, is removed here. This is a little bit enlarged lymph node here, which is removed along with the lymph node.
So the first incision is between the two obliterated umbilical arteries, more or less, right?
We want to be, yes, sir. We want to be a little bit lateral to the first incision posteriorly.
Yeah.
Right. So the deepest point of pouch of Douglas about an inch anterior to it. Once the lymph node dissection is completed, we drop the bladder. So bilateral lymph node dissection has been done. And we are dropping the bladder. So basically entering the space of Ritz. Yes, you can see the vas on both the sides there. You want to drop the bladder completely, you have to drop the bladder off the vas on both the sides. And now we are able to see the prostate here directly and the bladder here. And we are able to make an incision between the prostate and the bladder.
So this is usually you identify.
Most of the surgeons would
putting a tug on the Foley's catheter.
You can do that, or you can use this method which I'm showing. You can palpate the prostate from both the sides. And as a result of that, we can see the compressibility of the prostate and see the junction of the point where we are able to transition from the prostate to the bladder.
So many surgeons now would like to preserve the bladder neck. So what is your take? Do you actually kind of preserve the bladder neck and go as near to the prostate capsule as possible?
In patients who have a low risk disease, you can do that. But otherwise, in intermediate and high risk disease, usually it's not recommended because you may end up with a positive surgical margin if there is a tumor at the base. So we have gone through the anterior and posterior bladder neck, and we fall into that empty space behind the prostate where the seminal vesicles and the vas have already been dissected. So we are lifting up the seminal vesicle and the vas. And now the time has come to do the neurovascular bundle preservation. So these are the prostate pedicles. This is the base of the prostate. These are the prostate pedicles. This is the area where the rectum is. So we clip those prostatic pedicles and go along the posterolateral surface of the prostate and sweep off the neurovascular bundles right till the apex of the prostate. So all these are neurovascular bundles. Remember that when you're doing a radical prostatectomy, you will never be able to see the nerves. The nerves are microscopic. Even with a magnification of the robot, you cannot see the nerves. So you basically identify the neurovascular bundle by the presence of the vascular component of the neurovascular bundle. So where are the veins? Where are the arteries which flow in the neurovascular bundle? That is what you identify, and you sweep off the neurovascular bundle and you dissect all around the prostate till you reach the apex. So now these are the fibers of the levator. We are going all around here, going right till the point where the urethra is joining the apex to the prostate. So this is the dorsal venous complex here. This is the junction between the prostate and the urethra. And these are the puboprostatic ligaments. This is the right puboprostatic ligament here, which you can see. And once we have done a similar dissection on the left side, we go ahead and divide the puboprostatic ligaments here. And we go ahead and divide the dorsal venous complex. That's the difference between open and robotic surgery. In open surgery, this will bleed like anything. You can lose a liter of blood in a few minutes. But because of the pneumoperitoneum that you have in cases of a robotic approach, you are able to have a situation where you don't have the need to actually take a DVC stitch even initially. You need to take the DVC stitch only after you have divided the DVC. But of course, you can't do that in open surgery.
And this probably helps in over
the urethra from the apex.
So, Gagan, do you think this?
Yes, so it's been said that some of the trials
would help in overall continence rate.
There is some evidence to show. There is a study published which shows that if you do an initial, if you don't take the DVC stitch earlier and divide it, cold cut, and then suture it, there is an earlier return of urinary continence. But in the long-term continence recovery, there hasn't been found to be any difference. That means that about 1 year you will have equivalent continence, whether you take the DVC stitch earlier or whether you take it later. This is the Rocco stitch, which Saurabh had mentioned about. And this is when you bring the bladder down to the urethra here with the help of this Rocco stitch. There is a little bit of a modification that I do, and this is actually Dr. Vipul Patel's modification. So Anup would know about this very well. He also uses the second layer of the Rocco stitch to actually do a mucosa to mucosa anastomosis between the bladder neck and the urethra. And with that, he is able to create a posterior urethrovesical plate. So I have been doing that now for the last 10 years, and I find it pretty convenient. This is the main anastomosis. I don't want to really go into the very fine points of that, but basically what you're doing is that you're doing a continuous suture and bringing the sutures from both the sides and doing a approximation of the bladder neck and the urethra so as to have a water.
So this is probably a single knot Beethoven anastomosis, right? It's a usual.
Right, sir. So that's pretty much it now, because now all we need to do is test the anastomosis by putting saline inside it. And these are all the threads of the bags that we have for taking out the specimen, which we do with a Fresnel steel incision. A drain is put because an open retropubic prostatectomy is extraperitoneal by definition. I agree with Saurabh when he says that, okay, the drain has to be really low before you want to remove it. This is a transperitoneal operation robotic approach. And in this particular case, you can actually go ahead and remove the drain the next day, even if the output is 100 ml, 150 ml, because everything is going to be absorbed in the peritoneum in any case.
So in every case, right?
We put a drain in every case because firstly, it's mostly for the fact that when the patient is in a head down position, as you would be in a robotic surgery, there is a lot of, there can be collection of fluid and blood under the diaphragm.
Yeah.
When the patient becomes horizontal and starts walking around, you want all that to come out and not stay there.
Right.
And you all, especially when you're doing a lymph node dissection, also there it's probably a good idea to put it. But main reason is also to make sure that there is no leakage from the vesico-urethral anastomosis, because for that you will need to keep the drain for longer. So next day, if there is no leakage, if there's a doubt, you can do a drain fluid creatinine. If there's no leakage, you can go ahead and remove the drain even at a higher volume.
Right. We saw you putting a Surgicel before doing a Rocco stitch. Is it a routine?
Very optional. No, it's very optional. Most of the people would not do it.
Okay, so you put it routinely, or if there is oozing, then only you would?
Most of the times I would put it, but I think it's more like my sleeping pill rather than any benefit to the patient.
Okay. Now people are doing like clipless kind of nerve sparing surgeries. Like they may put a temporary bulldog clamp to the prosthetic pedicle and then do a nerve sparing to avoid any kind of injury to the nerve. So any take on that?
You can of course do that. I mean, there is, in fact, most of the times you can do a spot bipolar of the vessels in the pedicle of the prostate, and then you can dissect off the entire neurovascular bundle without having to put any clip, or you can also do a spot monopolar of the arteries only and leave the veins. When you're doing a nerve sparing dissection, the veins will invariably stop bleeding on their own, so you don't need to really worry about the veins, but these are the arteries which you have to take care of, and that you can take by any method, by clip, by monopolar, or by selective bipolar. Anup, you want to come in and take over now?
Yeah, Gagan, before Anup comes in, I would just ask you, do you usually go interfacial, intrafacial, or it will depend upon the actual anatomy and the malignancy of the prostate, where it is exactly? And then you will
almost never intrafascial, almost never. So intrafascial is probably reserved for the lowest of low risk cases, where you actually even go all around the prostate in a kind of a veil of Aphrodite kind of a situation.
Right.
Most of the patients who are candidates for intrafascial dissection are also candidates for active surveillance. So they should probably not have a radical prostatectomy at all.
Yeah.
When we do nerve sparing, there are basically two kinds of nerve sparing that you can keep in mind broadly, from the exam purpose. One is a complete nerve sparing, one is a partial nerve sparing. A complete nerve sparing is invariably an interfascial nerve sparing where you're dissecting between the prostatic fascia and the levator fascia. And by that, you can save most of the neurovascular bundle, and you can expect about a 65-70% potency at about 1 year. And partial nerve sparing is basically what you're saying is, I'm going to excise half the neurovascular bundle and I'm going to preserve half the neurovascular bundle. Grossly speaking, there are like grades within that as well. But you're going to say that, look, I don't want to remove the entire neurovascular bundle. Patient is sexually active. He may get some response. At the same time, I don't want to stay very close to the prostate. So I will go a little bit farther away, leave about 1 or 2 millimeters of neurovascular bundle on the lateral surface of the prostate, go wider than the prostatic fascia, go through the neurovascular bundle, thereby giving a patient about a 40% chance, if he's previously sexually active, giving him to be normally sexually active at about a year. So there are wheels within wheels in that. And of course, wide excision is when you remove the whole thing because the patient is high risk disease.
Right. I think they have described the various grades of nerve sparing also. Grade 1 to grade 5. Grade 1 is the total nerve sparing. Grade 5 is no nerve sparing. I think, and they have also devised a kind of score also of safety. So to decide whether you want to do an intrafacial or interfacial. So people have done a lot of things. Anyway, so thank you, Gagan. Anup, you may come in and just tell us a few of your points that you want to make on the various steps.
So Dr. Gagan has covered most of the steps very nicely. I think we're running short of time, sir. I think
No, we can go ahead for 15 minutes now.
So first of all, for our residents who are listening, your first question will be asked to you is, which approach is better in radical prostatectomy? Whether you should go for posterior approach first or anterior approach first, because this is a very commonly asked question in the exams. So answer will be, considering the Indian scenario, in which we have a lot of high-risk patients, locally advanced patients who are coming for radical prostatectomies. The posterior approach is a better approach as compared to anterior approach, because in this approach, as Dr. Gagan has shown, you drop the seminal vesicles and vas deferens down in the first step, and rectum is also pulled down. So the chances of rectal injury is always minimized by using the posterior approach, and therefore the posterior surgical margins also, the chances are less. So this is one thing I think for Indian scenario, it's very important that posterior approach is better in the Indian scenario. However, if you see in the US counterpart, Dr. Menon described the anterior approach. Dr. Patel also does the anterior approach, but now many surgeons have reverted to the posterior approach. So because their disease is low risk and most of the time is intermediate risk, but in India, it is the other way around. So for India, I think the posterior approach is one of the better approaches as compared to anterior approach. Second is that DVC control is very important. Dr. Gagan has nicely shown. You are asked whether you should ligate DVC before cutting or after cutting. This is again, you should understand that for all exam going PGs and for the newcomers, you should always ligate the DVC first and then cut it, because in that way you will minimize the blood loss, number one, your vision will be better, and chances of apical margins will be minimized because you're doing it under vision. So these are two questions which are always asked in exams. If you are going in that way and getting the D viva, you can ask.
Anup, I want to ask you one question, Anup. Sorry to interrupt you. Before we go there, I want to ask you a question. I am a third year PG in SMS, Jaipur, right? As of now, I don't have a robotic system. I'm sure sir will get it very fast.
Yeah,
as of now, I don't have a robotic system. I'm appearing for an exam. You, of course, travel all over the country to take the exam. I am not an examiner, so I don't know about it. If I am asked a question as a third year PG of SMS, that would you okay, you'll do a radical prostatectomy, would you do an open prostatectomy or would you do a robotic prostatectomy? Would you recommend this patient to have a robotic prostatectomy? Would you recommend this patient to have an open prostatectomy? If an examiner is asking me this question, how should I reply it? I don't know the answer, that's why I'm asking.
So the examiner is asking the resident, you are the surgeon, because when we ask question to a resident, we consider that he is the operating surgeon. So if he has got adequate exposure during his training, that depends upon center to center. I am very sure Dr. Shivam does center lots of open radical prostatectomy. So if they are doing it regularly, he can say, yes, I can do open radical prostatectomy. He should not commit on laparoscopic or robotic, should be very honest. Now you land in problem when you start talking about robotic radical prostatectomy and you have never seen or done that. However, if your center is not doing a radical prostatectomy regularly, whether it's open or any other, you say, sir, I will refer the patient to a high referral center who are doing it more regularly. That should be the correct answer in the exams, because examiner wants to know whether you are doing harm to the patient or not. So if your assisted open surgeries, lot of cases, you can say, yes, I can do open radical prostatectomy. Of course.
So I think the what crux is to say is that unless so you have to confidently speak about the thing that you have done or you have seen, and open surgery is the gold standard. But by the fact that Anup and I both are our practice is almost exclusively robotic for prostate. So let's not get for the exam purpose. Saying that I would do open surgery for anything, whether it's prostatectomy, anything, is perfectly fine. You have to know the steps. If you know the steps of open prostatectomy, and you are able to say and justify it, I think that's perfectly fine. Is that okay, Anu?
Yeah, definitely. I mean, as a resident, you should never comment upon laparoscopic radical
Because
prostatectomy or robotic radical prostatectomy.
and probably in all the three approaches, results would not be not significantly different. So only maybe there may be some transient improvement in continence or potency may be higher with robotic, but long-term results probably would not be very different in all the three approaches if it is done by an expert. So
perfect. So one point that I would like to make to all the residents, the best thing that you can do for any malignancy is read the summary of the EAU guidelines for that malignancy. You may not even want to read the entire big stuff. If you just read the recommendations ke tables and revise those recommendations ke tables before your exam, you are set. Because in that, all these answers, ki lymph node dissection karna chahiye ya nahi karna chahiye, what is the extent of lymph node dissection, whether open surgery should be done or whether laparoscopic surgery would be done, all those answers you will get almost as if you are reading a guidebook. Because in that, it will be clearly written that all three approaches are equivalent. All three approaches are equivalent. They in the hands of surgeons who are experienced in a particular approach, there is no difference in continence. There is no difference in sexual function over a long period of time. Because I am experienced in open radical prostatectomy, I should say that I will do open radical prostatectomy because according to the research study, there is no conclusive proof that robotic prostatectomy is 100 times better than open prostatectomy. It's not there.
Gagan, when you have raised this point of guidelines, there is sometimes a confusion between the various guidelines, right? So the NCCN guidelines will tell you something different. The AUA guidelines will tell you. So what would you recommend the residents?
I think they should just read the EAU guidelines because they are comprehensively, it's updated every year. They comprehensively give the description and the references and the details of every single point. They make very good summary tables and very good recommendations for your exam purpose for these 5 urological malignancies. There are only 5 urological malignancies.
Yeah.
For these 5 urological malignancies, just read those tables. Don't even read what's inside. Just read those tables and you will be prepared for 90% of viva and 90% of short notes that come for this malignancy.
That's great. That's a very good tip to the residents. Anup, do you have anything on the
I wanted to show a couple of slides for the residents to
please
highlight some important steps because surgery has been already shown by Dr. Gagan. So I will just highlight few important slides which are asked from the resident in different section of exam, whether it's a theory case, a theory question or a practical. So I'll just share. I will just I'm allowed to, sir, share.
Yes, I think I would request the technical support team, please allow Dr. Anup to share.
Yes, sir. Sir can share this screen.
Yes, please. Please allow.
Allowed? Okay. I think now you can see.
Yeah.
I just wanted to tell about number one, port placement. I think before they go for the surgery, if sometimes in the theory exams or
Hello, sir, sorry to interrupt. Can you minimize that video panel because it is covering the PPT?
Okay. Yeah. So now
Yeah.
see just for the residents, the port placement, because when they ask you some of the steps of surgery, they might ask you for the first of all the port placement. So just wanted to show the port placement. I think this is given also in your Campbell, and you should remember this is for the laparoscopic and SI robot. The 5 port placement, 1 in above the umbilicus, 2 in the lateral border of rectus, and 2 in the iliac fossa. This is for lap and SI robot, and this is just let me show the robotic one also. and then I will go to the slides. This one. So in the XI robot, all the ports in the same line. So this, I think this thing, if you get a question, a theory question about steps of radical prostatectomy, at least you can draw this diagram. Now I want to just show you the apical dissection, the slide only. So you might get out of these four one of the apical shapes in your radical prostatectomy. So out of this, I think if you can draw this kind of diagram in if they ask for apical dissection in radical prostatectomy, you will get more marks. And the best out of this is the type D, in which the chances of the positive surgical margins is minimum. The maximum urethral length is there, and also the continence will be higher in this kind of patient. So this is the best one, but often we get other kind of configuration, and that's why this is the reason for, if you cut here, let us say in C type of configuration, I cut here, I will get a positive surgical margin here. And also the here also you can see, if I cut here, the length of urethra is less. So I think this kind of apical shape you should know, and if you can draw a diagram like this, I think very important. Now talking about the steps, I just want to show what things you should keep in ready for your surgery. These are the instruments for lap or robotic. I think details, you might not go into the details, but one thing is for sure, always keep a rescue stitch for the vascular injury. If you talk like that in the exams, examiner will be very happy, because they know that now this surgeon is worried about the complication. So keep the vascular stitch ready, and always keep an open trellis ready. So these are two things as a resident you should always tell if they ask you for the preparations you do for the surgery. I think rest of the things have been covered by Dr. Gagan, so I'm not going to show any video. I just want to highlight the post-op management, because this is something which they can ask you, that if you have done the surgery, how will you manage the Foley's catheter? So most of the centers, they remove the Foley's catheter 7 to 10 days after the surgery. And if you are not sure about the anastomosis integrity, you might do a pericatheter ureterogram. However, this is not being done routinely in most of the centers. So your answer should be, if I am not sure about the integrity of anastomosis, I will do a pericatheter ureterogram at 10 days. If there's a leak, I will keep Foley's for additional 7 days, and then I can repeat the study. But if you are very sure about your anastomosis, you can safely remove the Foley's after 10 days. So this is, I think, the part of your post-op management. And then, of course, they can ask you how to manage complication. Your Foley slips out in the post-op period, how to manage. I think those are the questions they might ask you. But I think we are short of time, so I think I would like to stop here.
So, Gagan, would you like to add anything on the penile rehab after the surgery?
Two quick points, sir. The first point is that Anup has already mentioned. One of the questions that can be asked theoretically is that you've done a radical prostatectomy. Next day you come to see the patient in the morning. Urine output is 500 ml in the last 24 hours. Drain output is 1200 ml. How will you manage the patient? So the obvious first answer to that question is, I wish we had time to actually have an interaction with the third years in this. But the first thing to do is do a drain fluid creatinine, because you are suspecting a urine leak in this situation. Drain fluid creatinine comes out to be 23. What is the next step that you will do? You know that there is a urine leak. What are the two places from which the urine leak can take place? One place is that you have done a vesicourethral anastomosis and it has leaked. The second possibility is that the patient you have injured the ureter during the dissection. So you have to find out whether the patient has a leak from the ureter, which you have inadvertently injured during your lymph node dissection or the posterior dissection, or whether there is a leakage from the vesicourethral anastomosis. How are you going to do it? You are going to do a CT urogram. CT urogram, if it shows intact upper urinary tracts and the ureter draining freely into the anastomosis. Next question, how will you manage this patient? It will depend upon the clinical condition of the patient. If the patient is clinically stable, if the patient is not having any peritonitis, if the patient's abdomen is soft, you can keep the catheter in place and continue conservative management, a lot of these leaks may heal on themselves if they are from the vesicourethral junction abnormality. However, if this patient is unstable, if the patient has signs and symptoms of peritonitis, then the best answer that you can give in this situation, if the patient is unstable, is to do probably a bilateral percutaneous nephrostomy, but that almost never happens. If on a CT urogram you have found that this patient has a ureteric injury, what are you going to do about it? The safest answer in this case would be that if there is a complete transection of the ureter, I would do a percutaneous nephrostomy on that side. I will wait for the drain output to become 0. I will send the patient home on a percutaneous nephrostomy. After a waiting period of 2 to 3 months, once the patient is settled, I will call him back, do an antegrade nephrostogram, see what is the level of obstruction, level of leakage, and then plan further treatment, which may include ureteric reimplant, which may include or a Bovary flap. So this is one thing that I wanted to elaborate. Rehabilitation should be done only in patients who have normal preoperative sexual function and who are interested in retaining their sexual function. Penile rehabilitation doesn't really work. Can you hear me, sir?
Yes, yes, please.
Yeah, penile rehabilitation doesn't really work in patients who have not had a nerve sparing operation, or who are obviously not sexually functional, in the preoperative period. Penile rehabilitation consists of two different things. One thing is to start these patients very early on a PDE5 inhibitor and encourage them to engage in some kind of a sexual stimulation so as to increase the blood flow to the cavernosal muscles. Penile rehabilitation, depending on where you are getting it done and your own principles, also sometimes includes giving intracavernosal injections with prostaglandin to induce artificial erections. And it should start as early as possible after surgery. It has been found that patients who undergo this penile rehabilitation program end up having a higher chance of spontaneous erection at about 1 year after the surgery. You don't really need to go into the details of how it is done, how many times a day, how many times a week, and all those things are really not required. I think what basically means is that we generally use two methods for penile rehabilitation: oral PD5 inhibitors and intracavernosal injections. When should you start it? As early as possible after surgery, maybe even from the day of the catheter removal. In whom should it be done? It should be done in patients who have had a bilateral nerve sparing procedure in a gentleman who was previously sexually active and is interested in retaining his sexual function.
That's a wonderful kind of explanation of exactly how you post-operatively manage these patients. I think we are running short of time. So thank you, Gagan. Thank you, Anup. Both of you, you did a wonderful job, and I think the residents must have been benefited a lot. Dr. Somendra, are you there? Dr. Somendra? Dr. Somendra Bansal?
Somendra is my old friend from Vedanta.
Right. He was with you, and then he has joined just last year only. So thank you once again, both Dr. Anup and Dr. Gagan. It was a wonderful presentation by the resident, and then both of you really did a good job in explaining the steps of radical and how to go ahead. Thank you very much, and thanks to all the viewers, faculty members, and the residents of our department. Thank you very much.
Thank you, sir. Good night.
Thank you, sir.
Good night.
Thank you for your kind invitation and the opportunity, sir, and wish all the best to all the residents. May you crack your exams in style.
The only drawback about this last 1.5 years, our hospital has been converted into COVID. So only there were 3-4 months in between we could do surgery. So that is a real disadvantage and very unfortunate thing for the residents. They could not see a lot of surgeries. But anyway, we will try to compensate as much as possible in the coming time. Thank you again. Thank you, Anup, and thank you.
Thank you, sir. Thank you.
Thank you, sir.
Good night. Good night, sir. Good night.
Good night.